Hello ladies and gentlemen. Thank you very much to the organisers for asking me to speak on my approach to primary tube surgery. I have a number of financial disclosures, and specifically I have a financial interest in the Paul glaucoma implant. The primary tube versus trabeculectomy study, or PTVT study, was a randomised clinical trial of the 101-350 Barveld implant versus mitomycin trab. The mitomycin trab is 0.4 milligrams per mil for 2 minutes. The primary outcome was a cumulative rate of surgical failure at 1 year, as defined in the study. The study organisation involved 29 investigators at 16 clinical centres, 13 of whom were in the United States and 3 in the United Kingdom, although I must point out that the 3 United Kingdom centres provided 40% of enrolment. Eligibility was uncontrolled glaucoma with no previous surgery, and all eyes were phakic. And the study recruitment flow is on the left. 256 were randomised. 131 assigned to the tube group, 125 to the trab group, of whom 125 tubes received the assigned treatment, 115 trabs. A number have lost to follow-up or passed away, and 103 tubes and 97 trabs completed the 3-year follow-up visit. This graph is from the 3-year outcomes paper. At baseline, the average pressure was around 23 to 24 in the two groups and wasn't significantly different. The trab group had slightly higher pressures and slightly more medication. At 3 years, however, the trabs had slightly lower pressures than the tubes on slightly less medication, and this actually was highly statistically significant. And this is illustrated in this graph. When we look at alternative outcome targets, if failure was defined as a pressure of more than 17 or less than 20% drop from baseline, there was still a difference between trabs and tubes. But if we lower the target to greater than 14, you can see that trabs and tubes did equally well or equally badly. The primary outcome measure was the cumulative rate of surgical failure at 1 year. Surgical failure was defined prospectively as a pressure of 21 or more, or reduced by less than 20% from baseline on 2 consecutive visits after 3 months, or a pressure of 5 or less on 2 consecutive follow-up visits after 3 months, or reoperation for glaucoma or loss of light perception. Complete success was defined as patients who had not failed by the above criteria and were not receiving supplemental medical therapy, whereas a qualified success was patients who had not failed but required supplemental medical therapy. The baseline characteristics show that the ages were around 61 to 62 mean, more males than females, and roughly equal number of blacks and whites, though slightly more blacks. The mean starting pressure was around 23 to 24, as I've mentioned, and on 3.1 medication in the tube group, 3.2 in the trab group. And the vast majority were primary open-angle glaucomas. As you can see, did not exclude pigmentary or exfoliative glaucoma, and a significant proportion of patients had previous laser treatment. The primary outcome at 1 year shows that the risk of surgical failure was much higher in the tube group than the trab group. At 3 years, the difference was not so obvious, but the primary outcome measure was at 1 year. At 3 years, it was not significant. So at 1 year, you can see that the majority of surgical failures were actually for inadequate IOP reduction or reoperation for glaucoma, which is pretty much the same thing, really. There were a lot of postoperative interventions in both groups, a lot of removal of ripcords, i.e. supramids in the tube group, quite a lot of laser suture lysis, 5FU injections, needling in the trab group. Overall, there wasn't much difference in postoperative manipulations in total. Early surgical complications, i.e. within the first 3 months, were higher in the trab than tube group, but late surgical complications were similar between the two groups. What do we mean by surgical complications? Well, there were a lot more wound leaks in the trab group, perhaps not surprisingly, slightly more hyphemas in the tube group, Encapsulated bleb is listed as a complication. My personal feeling is that that was probably a mistake because it's a fairly woolly diagnosis and it's not really a complication. And again, late complications, encapsulated bleb is listed again. The 5-year outcomes and complications have been submitted for presentation at the AAO if you can make it to New Orleans. So the role of primary trabeculectomy is in patients at a high risk of visual loss who don't have other failure risk factors, such as eyes that look like beetroots from too much medication. The role of tubes, well, tubes work on almost anyone, except low-risk cases in which trabeculectomy is likely to give better IOP control. So when are primary tubes indicated? Well, usually not in primary open-angle glaucoma with no other failure risk factors, unless follow-up is likely to be challenging, or situations where post-op manipulation is likely to be impossible. But more importantly, there are many secondary glaucomas and other primary situations where trabeculectomy has no hope of success. And there's a very long list of situations with conjunctival scarring, thin sclera or inflamed sclera, proliferative conditions, future requirement for corneal grafting, i.e. corneal disease, previous retinal surgery, very small eyes such as microphthalmos, nanophthalmos, those in whom there is a very high risk of hypotony, and those in whom there's a very high risk of severe visual loss should hypotony occur, such as Sturge-Weber. So tubes do work on almost anyone, but it also depends on which tube you use. The current most commonly available tubes are the Amid glaucoma valve and the Barvelt glaucoma implant. There were 2 randomized clinical trials comparing these, and both happened concurrently, the Amid Barvelt comparison study and the Amid versus Barvelt study. 2 simultaneous RCTs with similar results, the Barvelt giving better IOP control, but the Amid with a better safety profile. And if we pool the results of these, and that adds up to 514 randomized patients with 170 in each group at 5 years, which is quite a good number for analysis. And you can see when the results are pooled, the Barvelt does give lower pressures than the Amid on fewer medication. And this is not just statistically significant, but I think it's quite clinically significant that 5 years, the pressure is roughly 16 in the Amids and 13 in the Barvelts, and the Barvelts are on fewer medications as well. So tubes do work in almost everyone to some degree, except low risk primary cases, and specifically those with low starting pressures. But this specifically relates to the Barvelt 101-350. So is the Barvelt 101-350 applicable to anyone who needs a tube? Well, no, it isn't, and this is very important. There are those with high risk of hypotony from tubes such as JIA, chronic severe uveitis, multiple CPCs, chemical burns. The Barvelt is really not for these patients, and it is a mistake to assume that one size fits all. And specifically, if you use mito with tubes, you should not use it in these cases. Severe JIA or severe uveitis from early childhood, you really need to avoid mito and consider something like a single plate Maltino or a 250 Barvelt or an Amid valve. And the same is true of severe ocular ischemia, such as severe neovascularization, as we used to see prior to the introduction of anti-VEGFs. And you can get severely burnt by using the 350 Barvelt in these. As I mentioned, the single plate Maltino, which is not completely confined to the history, but can be useful in the eyes that have very low aqueous output, and those are severe uveitis from early childhood, multiple previous cyclodiodes, or severe chemical burns. The 250 Barvelt in the full frame has a smaller plate obviously than the 350 and is more appropriate for eyes that again have a significant risk of chronic hypotony. With appropriate case selection, trabs will work much better and for much longer than the alternatives, but there are a lot of situations where trabs will not work, and the Barvelt works to some degree in almost anyone. but usually not in POAG with no other failure risk factors unless follow-up is challenging and post-operative manipulation would be challenging. And there are many types of secondary glaucoma or high scarring cases where TRAB just wouldn't work. The only real innovation of late in tube implantation is the pole glaucoma implant, which has a smaller tube.
The tube lumen of the pole glaucoma implant at 127 microns in diameter is significantly smaller than that of an amide valve or a Barvelt or a Multino implant. The pole can therefore be occluded with a 6-0 Prolene suture to reduce flow, rather than the 3-0 which is required for a Barvelt or a Multino. The tube is typically stented all the way into the anterior chamber. In most cases, this provides enough resistance to prevent early hypotony. The Prolene stent is seen here in the anterior chamber on gonioscopy. In contrast to ligation of the tube, which risks a high early pressure, stenting permits regulation of aqueous flow through the tube. Aqueous can be visualized emanating from the back of the tube and the flow rate roughly evaluated. A dry sponge is inserted into the small well at the back of the plate, and then slow aqueous filling of the well should be visible. If the well cannot be seen to be filling slowly, the pressure is likely to remain high in the early postoperative period. On the other hand, if aqueous drainage is brisk, then there will be a very high risk of early postoperative hypotony, as in this case.
So what?
The tube portion is not very much larger than a PreserFlow. Compare the tubes in luminal diameters here. The Barvelt is the one on the top.
One problem with tubes is endothelial cell loss and erosion, and a smaller tube is simply likely to give fewer problems in terms of this, but this remains to be proven. So the Barvelt 11350 does produce good IOP lowering in primary glaucomas who have had no previous surgery, but is less effective than a TRAB. The indications for a primary tube, despite PTVT, are situations in which frequent follow-up would be impossible, post-operative manipulation would be impossible, or a TRAB would be impossible to perform or unlikely to work. The pole glaucoma implant is a smaller tube that may result in less long-term morbidity than the Barvelt and seems to have similar efficacy, but this remains to be proven. Thank you very much for your attention.